the case scenario. This may be, because this is a picture, not our boy from the net. So you have a, this to show you how the patient will look like for the benefit of those who have not had a chance to anesthetize a case like this. This will be the fetus of a child with a severe burn contracture. You can see the neck is in a fixed position and the lower lip is averted, and neck extension is totally impossible. So in this situation, the challenges are, it is already an anticipated difficult airway, and it's a pediatric age group patient who may not cooperate for a awake fiber optic bronchoscopy and may need sedation, but there is always a risk of loss of airway when you give the sedation, so it should be very cautiously done. So what are the options to secure the airway in this child? Can use a flexible fiber optic intubation under topical anesthesia. So what are the methods of applying topical or local anesthetic to the airway in this particular case?
Nebulization.
Very good. First and foremost is nebulization, which is a very easy and very tolerable method. Then
nasal drops, oxymetazoline nasal drops can be given.
They are decongestants.
Vasoconstrictors.
Topicalization means it is mainly application of local anesthetic. What percentage you will apply, how do you calculate the dose, and what are the methods of instilling that local anesthetic in the airway. These are the things you have to have. Applying xylomethazoline or zoline is additional precaution to prevent bleeding. But that does not give any local anesthetic effect.
Yes, sir.
So one is nebulization. Any other method? What is MAD?
A mucosal atomization device.
What is the difference between nebulization and mucosal atomic atomization device? The particles are much more bigger and the spray is much more intense than the nebulization. Okay, in nebulization, the particles are much more smaller and it is done by patient's own respiratory efforts. In the nebulization, patient inhales the mixture of local anesthetic, nebulized mixture of local anesthetic, and then inhales them. Whereas in the MAD, mucosal atomized device, you always squeeze it out and spray it on the mucosa. Okay, I'll show you pictures of that are available. And what are the varieties of MAD equipment? Where all you can use this MAD? Which location or anatomical sites you can use MAD? You can use it in the nostrils or in the laryngotracheal area. Okay, so you have devices for both. You can use nostril MAD or you can use laryngotracheal MAD. Again, I will show you the picture. And so the first option is flexible fiber optic intubation under topical anesthesia. The second is quick release of contracture under ketamine anesthesia, followed by direct your conventional laryngoscopy and intubation. Because once you get a good release, you are able to extend the neck. Why conventional laryngoscopy needs a proper position? What is the position? How do you describe the position for conventional laryngoscopy and what do you achieve by that position?
Sniffing air position, sir. Laryngopharyngeal axis will be in the straight line so that we can visualize the chords.
Sniffing air position does not have any anatomical description. It is a very artistic description. What are all the anatomical structures you bring into when you say the position for direct laryngoscopy? How to describe that? It's a very, very basic common question examiners may suddenly throw at you to destabilize your thought process. Okay. So the position that is done for direct laryngoscopy, your conventional Macintosh laryngoscope, if you want to use an intubate, you have to do flexion of the cervical spine and extension at the atlanto-occipital joint. This is the description you have to say. This morning sniffing air position and all is not accepted. Of course, this is only to make you understand. Do you do any morning stretches as soon as you get up every day? It is a British culture. They open the windows and go and they take fresh breath, inhale a fresh breathing, and then the fresh air. It's a culture in the British thing. So they describe that as
Yes.
sniffing the morning air and all that. But exam, if they ask you how to describe the position, you have to say flexion of the cervical spine and extension at the atlanto-occipital joint gives you axis in parallel. Which are the three axes? Oral
Oral,
axis,
pharyngeal,
pharyngeal axis, and laryngeal axis. All the three axes which are intersecting, if you don't do this positioning, will be brought into parallel to each other. And that will only help you to visualize the laryngeal inlet and help you to intubate. So please
Yes.
remember this point very well. It is a
Yes, sir.
flexion of cervical spine and extension at the atlanto-occipital joint, bringing the oral, pharyngeal, and laryngeal axis parallel to each other. That is what we have to say for this. And tumescent infiltration and release under sedation is mask ventilation. Again, mask ventilation should be possible. Then hybrid trachea using video laryngoscopy and flexible fiber optic intubation. And how to sedate this child? IV remifentanil, IV midazolam, and IV dexmedetomidine are the drugs which can be safely used, preserving the spontaneous respiration and adequately topicalizing the airway. That is a very, very important thing because half-hearted local anesthetic application can induce laryngospasm when the child is sedated. So because the child is not fully conscious, it will develop laryngospasm. So topicalize and wait for the effect to come on and then try to do the intubation. So this is what I have been telling you about the hybrid technique. You can see one person is holding the video laryngoscope. You can see the scope here. The other person is trying to intubate with the
Fiber optic.
fiber optic scope. And this is a better picture to tell you the same thing. Yes, you can see the one person is holding a video laryngoscope with the monitor showing that the other person is intubating using the fiber optic bronchoscope as a stillet in an endotracheal tube. The other person is intubating. So this is called the hybrid technique of intubation in difficult or challenging area. Especially this is done in a small boy for difficult intubation. So these two, when combined, that is called the hybrid technique. There are some guidelines which you have to follow. It is called the Difficult Airway Society Awake Tactile Intubation Technique. Okay. So first thing is topicalize. So how to do the topicalization is giving all the time you have to oxygenate. Whenever you do it in an awake patient, first thing is you ensure that oxygen is being given as a high frequency nasal oxygen or titrated to 30 to 70 liters per minute and continue high frequency nasal oxygenation throughout the procedure. And this is for adults as well as cooperative children. You can follow this guideline and you can topicalize the airway by using 10% spray to oropharynx, tonsillar fillers or base of the tongue. You can see all this structure. And you can use 20 to 30 sprays during inspiration. So if you use one spray of 10% lignocaine, how much of lignocaine you will be putting into the patient? 10 mg, fantastic, very good. So like that you have to be careful about the roof and you can use phenylcaine spray also and topicalize the airway, and if inadequate you have to reapply the local anesthetic, and further 5 sprays of lignocaine can be done at the tongue base, 2 ml the above and 2 ml below the vocal cord with an epidural catheter or a working channel of FOB or using the hand equipment, mucosal atomic device. And lignocaine spray, one spray is 0.1 ml, 10%, which is 10 milligram. And if it is 1 ml of 2%, you are using 20 milligram. And 4-phenylkane, 25 ml is equal to 125 milligram lidocaine with 12.5 phenylephrine for nasoconstriction. So you get a combined local with a decongestant available, that is called 4-phenylkane. If you don't have your Mesidion or Otrivin, oxymetazoline or other drug, you can use this. And sedate, if required, remifentanil PCA at the dose of 1 to 2 nanogram per ml. If second anesthetic is present, consider adding midazolam 0.5 to 1 milligram. Okay, and to this you can add your dexmedetomidine, which is not given in the guidelines, but in practice we can safely use that. And performing the intubation is select the appropriate tracheal tube. Patient should be sitting up. Ensure operator can clearly see the patient on infusion pumps and video screen. Clear all the secretions. For fiber optic, operator position facing the patient, because we are going to do it from the front. Consider bronchoscope airway of the oral route and swivel facing posterior. Whereas for video laryngoscope, operator position behind the patient, as you saw in the but in the hybrid, both will be behind the patient only. Only when you do purely fiber optic, you stand in front of the patient. Technique, you have to both will be at the head end. So operator position behind the patient. Consider bougie before induction of anesthesia. You have to do a 2-point check and do that. So this is the guideline that is given by the society. And for difficult mask ventilation, there is another guideline where give 100% oxygen, call for help. This is for pediatric age group between 1 to 8 years. And the first step, second step, third step, A, B, C is given. But this is not exactly for contracture release. This is generally for an anticipated difficult airway, where optimizing the head position is the first step. So adjusting chin lift, all these things are not possible if it is a contracture. So it has to be straight away for a fiber optic with a topicalization. And inserting a oropharyngeal airway can be done in light anesthesia, even in contracture neck. But that so you have to choose a smaller size, because it will take this flex. If you use a regular size that you calculate, it may go and hitch on the epiglottis and create a stimulus, and laryngospasm will happen. So you may have to choose one size smaller for an oral insertion to keep the airway taken. And the second line is insert SAD. It is supraglottic airway devices. Of course, that also has been tried in patients with contracture neck, but type of supraglottic airway, which will be ideal? Huh?
Intubating LM.
Flexometallic one. Okay, intubating LMA will be more rigid, but flexometallic will be much more easy to insert and maintain in position. So that is what we have to use that. And what is shown in this?
Fiber optic bronchoscope.
Fiber optic bronchoscope with a handheld monitor. Usually, you know, the fiber optic scope, the light source will be connected and camera will be connected, and you will have a big screen in front of you to do the intubation. Whereas this is a present day portable fiber optic scope where you can have the monitor just like your video laryngoscope. You can visualize the, and what are you seeing here? What level is this?
Arena. Two
Arena. Very good. Right and left bronchial opening are seen. So this is a handheld fiber optic flexible bronchoscope. This is called a flexible intubation scope itself. And these are all the gadgets that you require for doing the hybrid technique. That is, especially when you want to put a double human tube, they advocate that you can use the fiber optic and then try to, you can see the fiber optic scope going through that, and this is the video scope which will be introduced, and so combining both will be useful. So visual double lumen catheter, visual laryngoscope, fiber optic bronchoscope. So visual laryngoscope combined with fiber optic bronchoscope results in what is called the hybrid type of intubation. Okay. So this is the pad atomizer. This is the through the nostrils for which you can use this. You can see the spray compared to your nebulization, it will be much more finer and a thinner moisture going through the entire mask. This is more specific and aiming at the mucosal of a smaller area. So this is a gadget that you can use. This is a flexible one. You can adjust it to various degrees. It can bend. It can adjust itself to the different types of nostrils. And these are all the cannulas that you can use for the same purpose. This is called the mad laryngotracheal cannula. And what is this L-Gamthori risk index? There are several risk indexes, like you are assessing the difficult airway, you have so many risk index scoring systems, starting from your Malambati and going on to
lemon spoon.
lemon. So what are all the indicators? Have you heard this name, L-Gantori risk index?
No, sir.
So this risk index has all these parameters: body weight, neck movement, mouth opening, ability to pronounce or upper lip biters like that, the gyromental distance, Malambati score, history of difficult intubation. So all these things are given 0, 1 and 2 points, combining these things. And so higher the point, better the difficult the intubation. Okay. So the lesser the point, better the intubation. So that is how the L-Ganzori score is recently introduced, involving all the other parameters which are used in so many other risk index scoring systems. I just thought I will put it because suddenly in the theory exam they are asking something new. So better to at least know that there is a terminology called L-Ganzori risk index and recall and try to select. So body weight, neck movement, mouth opening, ability to protrude your lower jaw in front of the upper jaw, gyromental distance, Malambati score, and history of difficult intubation. So 1, 2, 3, 4, 5, 6, 7 parameters have to be included according to the particular criteria to assess the difficult intubation. Okay. So that will be discussion on the pediatric